questions ready, which our host will be releasing throughout the session. Students will be able to drop their questions in the chat, and then we'll ask them to you during the second half of the session. And it'll be like an oral conversation. You don't have to keep up with the chat or anything.
Okay, that sounds good.
Wonderful. We're going to go ahead and get started. Welcome, everybody. Thank you so much for joining me today. We are going to start off with our mentorship networking event raffle. So if you guys don't know and you are new with pre-health shadowing, we are hosting a virtual mentorship networking event, which is a 3-day event. This will take place on February 19 to 21, and students will be able to meet and network with up to 6 established professionals in their potential field of interest. So if you guys are interested in joining us, you guys can enter in a raffle. This is by invite only, okay? And so the only way to get an invitation now is to enter in the raffle and to win. We will be hosting these at every single one of our live sessions up until the event date. And so you guys can submit 2 ways. The first way is by Venmo. The second way is on PayPal. So you guys, this will be open throughout the duration of today's virtual shadowing session, and we will be announcing the winner at the end of today's virtual shadowing session. All right, awesome. So I'm going to leave that up there for 1 second, and we are going to get started with a couple housekeeping things with pre-health shadowing before we begin. All righty. So welcome everybody to Pre-Health Shadowing. My name is Nina and I am the co-founder and CEO of Pre-Health Shadowing. Thank you all so much for joining us today. We do have closed captioning to accommodate students of all abilities and needs. If you guys have any more ideas about how we can become more accessible for our students, feel free to email us at info@prehealthshadowing.com. Pre-health shadowing allows students from not only places in the US, but all over the world to connect and learn about potential healthcare fields. So go ahead and drop in the chat where you guys are Zooming from today. I'd love to know. Wonderful. Thank you guys so much for joining us. All right, so a couple of things. Be sure that you guys are signed up for our email list. You guys can find this in the chat. You're going to go to our website, put in your email. We do send out 1 weekly email with all of the speakers' information for that week, so you can never miss a virtual shadowing session. We are booked daily until June, and so you guys can get 2 hours of virtual shadowing every single day with pre-health shadowing. Be sure to be following us on our Instagram at prehealthshadowing.com, at pre-health shadowing, for all of the information. All right, a couple partnerships that we have that have some wonderful perks for you. Our first partner is Kaplan. You guys can respond to the survey that we have just dropped into the chat to receive 10% off any Kaplan course. Not only that, but you'll also get free study guides for the MCAT, GRE, PCAT, NCLEX, and more. This is a wonderful resource if anybody's getting ready, even not if you're going to take it, in a couple months, even if you're planning on taking it in the long term, get it now. You guys can be prepped with it. We also have partnered with the women-led organization Fem Health, which is holding a Purpose Summit, which is a year-long membership to listen to 19 successful women and kind of gain some insight into their healthcare leadership and all of the things that they've been able to do. There is one woman who was on Shark Tank. She is the owner of a multi-million-dollar company. If you guys are interested in listening to what she has to say and getting insight from her, you guys can sign up for the Fem Health Summit. Use the link in our Instagram link tree for a really big discount. It's temporary. It's going to be $29 just for a little while. You guys want to do it as soon as possible. Hop on that because it's going to close soon. Alrighty. We have also partnered with the women-led organization Mask for Mask, which for every 4 masks that are purchased, 4 masks will get donated to a community in need, whether it be a under-resourced hospital or people in the homeless community. You guys, there's a bunch of different designs that you guys can get. Get 15% off your order when you use the code PHS15. And not only are you helping Mask for Mask and donating masks to other people, but you're also giving 10% of your purchase funds to pre-health shadowing to help us stay free for students everywhere. We are working to fight inequity in health education and promote diversity in the various fields. If you guys are interested in being a part of our student-based organization, you can become a team member in a leadership role, and you can also become a student volunteer. There's more information on our website. You can see the specific tasks that our student volunteers are currently participating in, and you can check out the Meet the Team page to see our current student team members. If you are a high school student, Pre-Health Shadowing now has a new group called HTP, which is a leadership and healthcare education pre-college learner program. You guys can get involved and establish Pre-Health Shadowing as a club on multiple campuses around the US. So that's a great opportunity to meet with like-minded students. If you are looking to get published, Pre-Health Shadowing is taking submissions. You guys can submit your writing to prehealthshadowing.com/blog submissions. We are taking articles, reflections, reviews, success stories, and anything that you guys are passionate about that you guys would love to share. All right, since we are a free, accessible, student-led nonprofit organization, we do ask humbly if you guys are able to donate at this time, that you please do so. This is helping us fight inequity in health education and promote diversity in the various fields. If you are financially unable to donate at this time, we do completely understand. All that we ask is that you please share this donate link with someone who you believe will donate that is passionate about helping you in your education. Thank you guys so much. All right, throughout the duration of the session today, feel free to drop your questions in the chat. Members of our student team will be taking those questions and asking them during the Q&A portion during the second half of today's virtual shadowing session. Don't forget to take good notes because the post-shadowing assessment will be available after the live session here today. And you guys will have any time after the live session to take it. You'll get 2 tries to get over a 70%, and I'll go more in detail at the end of today's session. Without further ado, I would like to welcome to you our professional for today. Thank you so much for joining us, Dr. Baxter. How are you?
Good. Thanks so much for having me on this virtual shadowing session. Just from an audio check standpoint, are you guys all okay, able to hear me okay?
Yep, you sound good.
All right, so I'll go ahead and share my screen. Unfortunately, my desktop app is not working great for PowerPoint, so I'm using Teams. So hopefully you can see, and then in case I get any messages, you'll probably see my notifications too. So I apologize in advance for that. Okay, so yeah, it's really funny that as you were doing your spiel, I heard you mention the doctor who had been on Shark Tank. She's actually an ophthalmologist and went to my same residency program. So it's a small world. But anyway, I thought we could get started. I know Nina asked where everybody was coming from and they put it in the chat, but I think we have a polling question just to get a sense of the spread of where you're from. And also, yeah, what level of training you're at. Just curious as to where everybody is in their journey. And then we'll get the results there once they're in.
All right, if you haven't been able to submit yet, go ahead and do so very quickly. I'll be closing it in just a couple seconds. All righty, I'm gonna go ahead and end the poll. Feel free to take a look around the room.
Oh, wow. A lot from the Northeast, Southeast, so mostly East Coast. So it's a little bit later in the evening for you guys. And a few people from outside the US. Wow, that's awesome. Level of training, most of you guys are junior, or I guess a third of you are juniors. Got a pretty good spread. I'm impressed that there are people in high school that are attending this talk, but that's great to have an early interest. All right, well, awesome. Nice to virtually meet all of you. And yeah, again, it's my pleasure to talk to you a little bit about ophthalmology and specifically academic ophthalmology, because it is a field that I feel like doesn't necessarily get, like, a lot of students don't get exposure to this even in medical school, and it's a fantastic field. And so hopefully we'll be able to pique some of your interest, and I'm happy to take questions as they come. So ophthalmology is a medical and surgical specialty focused on vision and eye health. Oftentimes we get confused with optometrists. People are like, oh, do you do like glasses and contacts? And while I technically could, that's not really the focus of our specialty. A lot of it is focused on medical, treatment of diseases of the eye, and also it is a surgical subspecialty. And I'll go into a little more detail here as we go along. But so it is distinct from opticianry, which are people who dispense glasses and glasses frames, as well as optometry. Optometrists also do, they do 4 years of optometry school after college, whereas ophthalmologists will do 4 years of medical school and then 4 years of ophthalmology residency. So you do have to go through medical training and do an accredited ophthalmology residency training, which in this country is 4 years. It does vary if you're in Europe or elsewhere. So just a little bit of basic eye anatomy. If we're looking at the front of the eye, you guys are all probably familiar with what an eyelid is, and you have eyelashes. The white part of your eye is called the sclera. And then this front clear portion, if we look at the side view, is called the cornea. The colored part, which can be blue, brown, hazel, green, any variety of colors, that's the iris. And the opening where there's not iris tissue is called the pupil. And the pupil is kind of like a keyhole where light goes through. And so if we look at the eye as a cross section, you can see that light will enter the eye through and pass through the cornea. And then go through this area called the anterior chamber. We'll go through that pupil opening. Then it'll get bent by the lens and brought into focus on your retina. And the retina is a neurosensory tissue that lines the inside of your eye, and it converts that light into an electrochemical signal that gets sent through the optic nerve and to the visual cortex of your brain. And that's how you see. So everything from front to back in the eye needs to be working correctly in order for you to see well. And obviously the connection to your brain, and your brain has to be working right as well in order for you to see clearly. And so a lot of our, decision-making and diagnosis depends on where we see problems in the eye and what layer of the eye it involves. And the eye is just like this amazing, intricate structure. And we actually have specialists who look at almost every individual layer. And it's a really cool specialty because people really care about their vision. If you think about all the things that you need your vision for, it's like these days it's really hard if you have poor vision, because like driving, reading, nowadays with so many things on screens and digital tools, it all requires our vision. And so it really is an important sense and an important aspect of quality of life. And so patients are very appreciative for what we do for them. And I think that's one of the biggest things that attracted me to the field was the ability to make a difference in someone's life through improving their vision. And also, it is this amazing organ, and there's so many different technologies and techniques that we use in trying to understand where the disease is and how to treat it. So as I was mentioning, there are several subspecialties within the broader field of ophthalmology. This includes comprehensive ophthalmology, which is what I do. It's also known as being a general ophthalmologist. You kind of do a lot of primary care ophthalmology and screening for different conditions like diabetic retinopathy, macular degeneration, glaucoma. We treat cataracts. I do a lot of cataract surgery. And so you can kind of do a variety of things. And then if you want to hone in on a specific type of, tissue or a specific type of surgery, there are different subspecialties for that. For example, cornea refractive surgery. A lot of those doctors will do LASIK, PRK, a lot of the new corneal refractive surgeries to help people see without glasses. Glaucoma deals with eye pressure and different surgeries and procedures to reduce eye pressure, to reduce the progression of glaucoma, which is an optic nerve degeneration that's fairly common, especially in older folks. Neuro-ophthalmology looks at that interface between the eye and the brain, and there's a lot of interesting conditions there that involve vision and neuroscience. And so things like myasthenia gravis, multiple sclerosis, different tumors, cranial nerve palsies, a lot of that falls within neuro-ophthalmology. The interesting thing is if you want to be a neuro-ophthalmologist, you can either do residency training as an ophthalmologist and do neuro-ophthalmology fellowship, or you can do it through neurology residency training, and also become a neuro-ophthalmologist that way after doing the fellowship. Ocular Oncology deals with cancer of the eye, oculoplastics and orbital surgery. They'll do a lot of the different eyelid surgeries. They do a lot of cosmetic and facial reconstruction. They also do tumors of the like orbit or the eye socket. Ophthalmic pathology, which is like a pathologist who specializes in eye tissues, and they'll do different sections and staining and different molecular analyses to be able to help diagnose different conditions of the eye. Pediatric ophthalmology and strabismus is focused on kids and eye misalignment. A lot of them actually will treat adults with eye misalignment and double vision issues. Retina vitreous is specifically focused on the back of the eye. So like retinal detachments, macular degeneration, diabetic retinopathy, a lot of different disease entities that retina specialists will treat. Uveitis is a subspecialty that deals with inflammatory disorders of the eye. And so they'll deal with a lot of the different infectious and autoimmune diseases that can affect the eye. There's a lot of sort of internal medicine overlap with uveitis, because sometimes they'll co-manage patients with rheumatologists, or they'll actually manage the immune therapy on their own. So there's a lot of variety in being an ophthalmologist. Like you could be someone who does high volume LASIK surgery, or you could be like, taking cancers out of the eye and being more like an oncologist. You could be, kind of a medicine doctor and doing immune therapy, immune suppressants as a uveitis specialist. You could almost be like a plastic surgeon, facial or ENT type surgeon doing eyelid surgery, or you do completely cosmetic. So there's so much variety in ophthalmology. And I think people sometimes have the misconception that, oh, it's just the eye. It's like so limited in scope, but it is actually a highly varied specialty with a lot of different options for specialization and a lot of different practice patterns depending on what your interest is. So I went over some of these, but these are some different conditions that we treat as ophthalmologists. Cataracts, which is clouding of the lens, glaucoma, which is an optic nerve degeneration, various conditions that involve like the retina, cornea, as I mentioned, different layers of the eye. We treat trauma, cancer, double vision, neurological problems. So it really is a large range of pathology that you'll see, and a lot of variety to the work. You're probably familiar with the saying, the eye is the window to the soul. I think this is one of the coolest parts about ophthalmology, is that you can look at a retinal exam or retinal picture, and you can make a diagnosis of what's going on elsewhere in the body. So there are very characteristic appearances when we look in someone's eye, and we can tell they have hypertension or diabetes, sickle cell, that they're premature. There are all these different systemic entities that we can diagnose with the eye. And I will say, in general, in medicine, there's a lot more usage of imaging and lab testing. And so your classic idea of, being a doctor guided by history and physical exam, sort of like, the way House does it on TV with, asking questions and sort of being a sleuth, as it were. A lot of that doesn't actually exist that much anymore in modern medicine, because we're so guided by lab tests and imaging. But I do feel like ophthalmology is one of the specialties where your physical exam makes a huge difference. So you being able to develop this very specialized skill of being able to look inside the eye. And often I would say, in 80 to 90% of the patients that I see, I'm able to make a diagnosis right then and there without ordering any lab tests. Obviously, there's eye-specific imaging that we do for many of our patients to guide management, but oftentimes you can make the diagnosis without imaging or testing. It's just based on your examination and your skill as a clinician. I think that's very satisfying too. And so, as I mentioned, ophthalmology is a surgical specialty. You get to, in residency, learn a huge array of surgeries. And this is definitely not an exhaustive list, but includes some examples. So like cataract surgery, which is where we remove a cloudy lens and put in an artificial lens implant. Glaucoma surgeries that decrease eye pressure. LASIK is an example of a corneal surgery where we're reshaping the cornea to correct refractive error. and reduce people's need for glasses and contacts. You can do retinal surgeries to fix detachments. You can realign someone's eyes with eye muscle realignment surgery, correct any drooping eyelids with eyelid surgeries, and as I mentioned, removing tumors with orbital surgery. And so these are some examples of before and after pictures of different types of surgery. I picked a couple examples like strabismus and eyelid surgery because they're more easily visualized, like you can kind of see it more clearly. But so this is a patient who had what we call an exotropia, or essentially an eye that's wandering out. And after eye muscle realignment surgery, he can look straight ahead. And same thing with these patients here. Again, you see before, some amount of eye misalignment. This is another patient with exotropia. This is a patient with what we call esotropia, or crossing of the eyes. And in each case, the eye muscle surgery results in alignment of the eyes. And you can imagine how big of a difference this makes in someone's life, both from a functional standpoint, as far as them being able to see, not have to see double all the time, but also from a cosmetic and social standpoint, especially, for kids as they're developing, really being able to get the eyes lined straight and working together is really important for their visual development. So that's a way to make an impact on someone for the rest of their lives, with a surgery that can be done relatively quickly. These are other examples from oculoplastic surgery. This is an entity called thyroid eye disease, when you have abnormal thyroid levels and it causes your eyes to bulge. There's essentially inflammatory infiltration of the eyes. And so there's a surgery that you can do called orbital decompression, where you actually shave away bone in the orbital bones that surround your eye. And again, restoring normal function and appearance. This is a picture of, someone with a really large orbital tumor that was removed. And so these are some of the, examples of surgeries you can do. Retina surgery, a lot of it, I like to tell people, it's like sort of like minimally invasive surgery of the eye. You have these ports, and, if any of you have worked with a minimally invasive surgeon who works in the belly, they do it a lot the same way. You make ports, you put in a light source, you put in a camera, and you put in an instrument to do the cutting and the work. In the eye, instead of 3 ports, we only need 2 for the light pipe and the cutting instrument. There is an additional port that we put in for infusion of fluid to keep the eye pressure stable. But we actually use an operating microscope that looks directly down through the pupil to be able to visualize the surgery. So this is, a picture of clearing out bleeding in the eye, which some people can get from diabetes, and it can totally obstruct someone's vision. And you go through and you can remove that blood. And that's a procedure called vitrectomy. Cataract surgery, which is what I do, is when you take this cloudy lens, and here, they're showing you this really white, dense, cloudy lens. And then once you remove it, they're able to see more clearly. And I can tell you, this is one of the most satisfying surgeries, and, big reason of why I went into ophthalmology. I had a gentleman who basically was white cane dependent. He had really dense cataracts and was afraid of getting surgery. And so he walked around with a white cane. And then, I did his exam, and it looked like the rest of his eye looked pretty healthy. And it was mostly the cataracts that were obstructing his vision. And so, after talking through the surgery with him, and then we did the surgery, he cried the next day because he said it was the first time he had seen his wife's face in 25 years. And he was walking around without the white cane on day 1. And so it's not uncommon to have stories like that, where you have someone who goes from literally being legally blind to seeing 20/20. And you can accomplish that with like a 10 to 20 minute procedure. So for anyone who's really into instant gratification, like, ophthalmology is great, because you see these profound improvements, and in a very short amount of time. And people are really grateful. They're grateful to be able to maintain their independence and keep on driving. They're grateful to be able to see their loved ones' faces. They're grateful to be able to do the things that we all, enjoy in life and often take for granted. Like if you have never had a problem with your vision, it's hard to sometimes understand what people go through. But if you can just imagine, only being able to see motion or only being able to count fingers but not be able to see letters, think about how it is to go from that to being 2020 and being able to drive again, walk again, see your loved ones' faces. I think it's a huge impact, and anyway, it's one of the best parts of the job. So like I said, some of the best parts about being an ophthalmologist, people really value their vision. You can have long lasting patient relationships. So there's some specialties where you have very fleeting interactions with people. Ophthalmology, you can sort of tailor, like some of the interactions can be shorter. Some can be long, like lasting over decades. And that's really satisfying. I think it's one of the only specialties really where you can do primary care and very highly specialized surgery. I think another example, a good example is OB-GYN, where you can do primary care like women's health and also do, complex surgery, C-sections and hysterectomies and all these other things. But ophthalmology is similar, where you can be a primary eye care provider um, and do like prevention type work and public health work, but you can also be a highly specialized surgeon. So it's a very broad spectrum of available work, and I like that variety. There's a range of procedures and surgeries. You have a lot of interesting medical decision making. There's some surgical specialties where you may not do as much in the way of diagnostics, like an oncologist or an internist or hepatologist. Like somebody else will work up the patient and come up with a diagnosis, and they'll send them to you essentially to like cut out the tumor or to do the surgery, but then you're not doing a lot of the medical management. So ophthalmology is one where you do get to do a lot of medical management as you like. And so some of the specialties like ENT, urology, ophthalmology, I would say all have sort of medical and surgical components. And so that's something you're looking for. That's another benefit. As I was saying, like a lot of short-term gratification, quick results, improvements, very happy patients. There are relatively few emergencies, and it is a specialty with great work-life balance. There's a lot of technology integration in terms of diagnostic devices and imaging, surgical devices, and then AI. So the first FDA approved autonomous AI technology was actually an ophthalmology related technology to automatically detect diabetic retinopathy using fundus photos, using eye retina photos. So we're definitely trailblazers in AI and digital health technology. And that's another really fun part about being in the field. And then there is potential for engaging in public health and global health because eyes are kind of their own entity, and you can, we can go in and do cataract surgery and really change someone's life. There's a lot of global health opportunities that don't require sort of broad health system infrastructure. So for example, the Himalayan Cataract Project was one started by Jeff Tabin and one of his colleagues in Nepal. It's called Second Sons is the book, but it's just a fantastic story. And I had the privilege of meeting Dr. Tabin 2 years ago. But they essentially go out and do these cataract surgery camps in high mountainous regions where if you lose your vision, it literally could be life-threatening. But they're able to basically have like backpacks of their surgical equipment, go out and do very low-cost cataract surgery and get people functional vision. And it's just an amazing thing to be able to do. So there's a lot of global health opportunity too. So just shifting gears a little bit. So clinical ophthalmology, I think, offers a lot in terms of, as I mentioned, a variety of surgery, great patient relationships, great work-life balance. One of the things I thought it might be fun to talk about was what academic medicine is like. I'm an assistant professor at UCSD, and I do clinical care, seeing patients in the clinic, doing surgeries, rounding in the hospital on our consult service. But most of my time actually is spent in research and education. I have a joint appointment in our Department of Biomedical Informatics. I do a lot of work around big data and AI, predictive analytics. And it's been really interesting to be able to wear those hats as well and be involved in medical student education, graduate student education, um, and as well as for pre-meds. I have a couple of undergrads who I'm mentoring right now at UCSD. There's a lot of intellectual stimulation, a lot of time in meetings, talking about ideas, writing papers, doing different research and analyses, and of course, a lot of rewards for training, motivated and bright students and residents and fellows. So I know the pre-health shadowing guidelines were saying, tell us a little bit about your background and how you got to where you are now. And so I did go to Duke for undergrad. I was a bio major and I minored in physics. I did like a genomics certificate. After that, I did a master's in public health at the London School of Hygiene and Tropical Medicine. That's actually where I met my husband, who was also an MPH student at the time, and went to med school at Penn in Philly, and then came out to UCSD, which is my hometown, for both my ophthalmology residency and my fellowship in informatics. And some of the pictures from my younger times, I actually ran into Carlos Boozer, who was a Duke basketball player and then ended up playing for the NBA for a while, randomly when I was like on a cruise to Alaska. It's a picture of me and my friend in London, where I studied during my master's. My husband and I at my white coat ceremony as a first year medical student at Penn, and then with my residency program here at UCSD a few years ago. My typical week is anything but typical or routine. As a result of being, an academic ophthalmologist, there's a lot of variety in what I do, and every week looks a little different. But I do see patients in my clinic. That's what I was doing this morning, and I round on ophthalmology consults in the hospital afterward with the residents. I operate, primarily in cataract surgery. I will also staff or teach medical students and residents when they're operating or seeing patients in the clinic over at our VA here in San Diego. On the informatics side, I am the liaison between our ophthalmology department and the larger health system IT group. I do some telemedicine as well. I interpret retinal images sent from our primary care sites where they're doing diabetic retinopathy screening using cameras. And then I read the images and send them the interpretations and let them know who needs to be seen in person. I teach courses to ophthalmology residents as well as med students and informatics students and their postdocs. Most of my time, like I said, is a mix of conducting research meetings. I write papers, write grants. I have mentoring sessions and teaching sessions with various trainees. And I also just started a sort of public health community-based screening program for eye diseases in underserved areas in our because San Diego is a border region, we have a lot of unmet need and a lot of people with difficulties accessing care. And so I've been involved with that a lot as well recently. So back when I was a pre-med, feels like, well, I mean, it literally is like a lifetime ago now, but I did a number of different activities when I was in college. I worked in a Drosophila genetics lab and spent a lot of time with fruit flies. It was a great experience. I ended up not wanting to continue with basic science research, but research obviously is a big part of my life right now. And I think the training that I got there around just the scientific thought process and the academic environment was hugely influential in my decision to pursue that for my overall career. I was a pole vaulter for Duke track and field. I was, I did it in high school. I was recruited to a couple of D1 programs, and Duke was an amazing combination of athletics and academics. So I ended up doing that. It was definitely a challenge. I would say if any of you guys out there are also student athletes, it is it definitely a boon and a help to your applications for med school, because people recognize how much of a time commitment that is and your ability to multitask and stay organized and do time management. So definitely think athletics is helpful for pre-med, but also just for like quality of life and staying fit and, you know, getting that endorphin rush. But anyway, I don't pull vault anymore. That's sort of retired from that once I had kids. But I was an editor-in-chief for our campus science and technology journal. I did do some clinical shadowing at the hospitals at Duke. I taught ESL in the evenings and mostly got into it because I wanted to keep up my Spanish skills that I had developed in high school, but it ended up being a super gratifying experience, and working with immigrants in the area and teaching them English. I did a number of summer research internships at different labs, both in San Diego and at Duke. And then I did do some study abroad. One summer I was in China, another summer I was in the UK and Oxford, and that influenced my decision to go there for my public health degree after college. One point I kind of wanted to touch on was raising a family during training. I ended up having kids very early, and it's definitely doable. I think attitudes are definitely changing. Just this past year, the ACGME, which is the like accreditation council for graduate medical education, basically that's the governing body that manages residency programs across the U.S. Are allowing parental leave during residency. And that's actually, I mean, it sounds like maybe obvious to you guys in your generation, but that's a huge deal because, maternity or paternity leave was not even existent, even when I first had kids, only 10 years ago. So, I had my first kid as a first year med student, the second one as a third year med student, and the last one as an intern. And it was definitely busy, but you just try to get the right family support, and don't strive for perfection. You can't necessarily always have like a homegrown gourmet meal with like all farm to table ingredients or whatever, but the kids will be fine. So now for sure it's in some ways more challenging with the pandemic and distance learning and all them having to go through school, even more so maybe than when they were babies. But I think that I think if, especially whether you're a man or a woman, if you're interested in having a family, but you also want a career in medicine, those things don't have to be at odds. Like schools are more supportive now, and I think that do it when it's right for you personally. I've seen a lot of friends struggle with infertility because they waited a really long time to have children, thinking that it would be too much of an impediment to their medical career and their training. And then, in some cases ended up spending tens of thousands of dollars to go through IVF and different reproductive technologies. Other times having, a lot of complications or not unable to start a family. And so I am always a big proponent of doing what makes sense for you and your personal life and, your medical career. It's such a long road. It is a marathon. And I think it's definitely possible to prioritize your personal life and your own well-being. And if having family is part of that, then prioritizing that, and you'll still be able to, make it through the training path and still have a successful career. General advice for pre-meds, I think doing shadowing and getting exposure to different environments to make sure that medicine is really the right path for you. There's a lot of ways to make an impact on healthcare without directly being a clinician. And so, a lot of my friends who started out as pre-meds later on realized like they wanted to do health policy, or they wanted to do public health. They wanted to do research. They wanted to do government. Like, there are so many different ways that you can make an impact and still make an impact on health specifically. If you find that maybe being a clinician is not exactly the right path for you. Because I think you need to have that mindset of like really knowing that this is like your calling and that it's really, something that drives you, and that you want to do, because it is a very long road, and there's a lot of burnout. Rates of burnout are at very high levels, especially in the U.S. And there are times during the training pathway where you will be taxed and you will be challenged, where you're sleep deprived and you're working like 100-hour weeks and you're not seeing your families, and you have no time for hobbies and no time for anything fun. And so during those times, you want to know that this is exactly, what you wanted to do, and to have those goals in mind, because that's what keeps you going when you have to go in at 3 a.m. and you worked a whole day the day before and you're going to work a whole day the next day. Um, you really want to know that this is the path for you before putting yourself in all those situations, because it is a tough road. And so you want to make sure that it's the one you want to take. And there were other roads that, you could have done more easily and would have been preferable. So I think that's a big part of it, is making sure that it's the right path. Part of that is, shadowing, volunteering to get experience. Definitely doing research or service helps at every stage. Do activities you're really passionate about. You don't need to spread yourself too thin. And I do see people who just try to do a laundry list of activities, thinking that they're like checking boxes on the application. But then if they're not doing things they actually enjoy or passionate about, they get a little bit burnt out, even at a very young stage. And you don't want to be a burnt out pre-med, like you have literally like a decade or more to go. So, I think, again, it's a marathon, not a sprint, and you want to be engaged in activities you really care about as you go along. I think it's important to do non-pre-med activities too, so it doesn't have to all be, shadowing and volunteering and, research. A lot of my most rewarding experiences from college were things that were totally not related to medical school, and or being a pre-med. And so I think that that's really important to build yourself as a whole person too. Find mentors. I had a lot of excellent mentors throughout my journey, who provided critical guidance and support. And I changed paths a couple times. Like I initially thought I wanted to be like MD, PhD in neuroscience. And when I decided I wanted to do the public health degree and not the PhD, it was a big, decision point for me. And my mentors helped with that. Obviously, when I was starting my family and trying to balance med school with being a new mom, it was really helpful to have mentors who had gone through that before, and able to support me. And I think the biggest thing is try to have fun. Obviously we're kind of emerging from some dark times, especially this past year. And so having fun, doing self-care, I think those are all really important things too. As far as admissions, I think probably you've had other talks where they've talked about this, but a big part of it is understanding your level of commitment, your academic achievements. It used to be people would want to do all these different extracurriculars to be well-rounded. We hear the term well lopsided a lot more these days, like trying to find, students who really bring a unique perspective, or they have a unique interest, or they've really well developed, one area. And so I think well lopsided is fine too. If you have something you're super passionate about, you don't need to feel obligated to do all these other things that you may not care that much about, but you feel like you have to do because you're pre-med. A lot of people are, will be moved by a compelling personal story or background. Certainly that's not necessarily, not everyone's going to have some amazing personal story. I certainly didn't, but I think that you just try to be reflective and really look at your own motivations and try to convey that when you are writing your essays. At the residency stage, they're looking for whether you're committed to that field. Letters of recommendation become increasingly important as you go along the training stages. Scores and exams get relatively less so. I would say it's more about how you work as a person. Are you a good team player? Are you like a good surgeon? And can people attest to to your ability to work with patients and work with colleagues. Those sort of soft skills, I think, become a lot more important as you enter the professional realm. So that's all I had for slides. I think I might have missed a couple. I forgot to do some of the polling questions. So maybe Nina or whoever is moderating could go through those. But yeah, I'm happy to take open questions and discussion if you guys have any.
Thank you so much, Dr. Baxter. I'm just going to ask really quickly, Barbara, do we want to do the polling questions, or are we good for questions from the chat?
We can just go into questions from the chat, and once Nina hops back in here, we can ask her about it.
Okay, sounds great. So yes, we have plenty of questions in the chat. I will also offer that if anybody in the room wants to come off mic and ask the question directly to Dr. Baxter, please raise your hand and we will set that up. But yeah, so I guess one of the first questions that we got in the chat was, what led you to a path in ophthalmology instead of optometry?
Well, I knew that I wanted to do, I think early on I was interested in being in a surgical specialty, and optometrists don't do surgery. It wasn't like when I was a pre-med, it wasn't like, oh, I have to do eyes. I was more like, oh, I want to be a physician and a surgeon. And so that was really more the path I went down on. I knew I wanted to go to med school, and then in med school, kind of got exposed to different fields and then got interested in ophthalmology. So it wasn't like I started out being like, oh, I really want to do eyes. And so is it optometry or ophthalmology? It was more like, I want to be a physician and surgeon. And that was really more the path that I took. I saw the next question. What's your specialty? I'm a comprehensive ophthalmologist, so I do general ophthalmology. My surgical focus is cataract surgery, but I decided not to do a surgical fellowship like retina or glaucoma because I primarily loved cataract surgery and I love the variety of comprehensive ophthalmology. So I decided to stay a generalist.
Thank you so much. Next, we can go ahead and I see some people raise their hands, and sometimes we let students ask you their questions personally. So Sarah, I saw your hand raised. If you would want to go ahead and ask your question, you can go for it.
Thank you so much. And thank you so much to Dr. Baxter for being with us. So my question is, and I was happy to see on the poll actually that we have at least 13% of us are actually post-bacs or career changers. I'm one of them. And I was curious, you obviously were pre-med track while in undergrad. I was actually a literature major, and I'm going back to finish my prerequisites. I was curious what you would recommend in terms of a master's in public health. I have a couple friends who also pursued that course, and I wanted to ask your opinion about it.
Yeah, I mean, I think, well, first off, being a post-bac is a wonderful route to take. I think we have, it doesn't necessarily at all handicap your application. In many ways, admissions committees will look at people who've had other life experiences and different backgrounds as an asset and benefit to incoming med student classes. And there are plenty of people who were humanities majors and non-science majors who flourish and do great in med school. As far as the Masters of Public Health goes, I thought it was a great degree. You know, when I was going through the program, there were sort of two types of students. One was like me, like straight out of undergrad, doing it before med school. And another group were largely consisted of people who had been doctors for many years already, and they were coming back to do a public health degree before moving into public health positions or more administrative or leadership positions. So I think either route would be fine. Part of me almost wishes I had done it later, once I had already had some clinical experience, because I think I would have gotten more out of the degree at that point. But, you know, I have no regrets, obviously, doing it before med school because it was a way to get a different perspective of health than what, you know, sort of this patient-centered or disease-based approach, organ-based approach that we do in med school. In public health programs, you're looking a lot more at social determinants, health in the broader context of society, and prevention efforts rather than treating disease, trying to prevent disease. And I think that's a really good perspective to have as well. But I think, the timing can vary. So you can either do a master's of public health before you start med school. A lot of people will do it during med school, like between their 3rd and 4th year of med school. And then some people will even do it later on in their career, once they've already had some years of clinical experience. So it just kind of depends on where your interests are at and where it makes the most sense for you personally. I know that some people who do it before med school, they might use it as a way to have their master's thesis and be like an academic product that they can use in their med school applications. Whereas people who do it during med school, at that point, they've had some exposure to the clinic. They have a little bit better sense of the health system. And then they also have a sense of what specialty they want to do. Then the master's thesis, they can use that coursework and the academic work to boost their residency applications, particularly if they want to go into a competitive specialty. And then, some people, they're a clinician for many years, and then they decide they want to switch routes and they want to be working in public health or in administration, and they'll do their master's, once they're well into their career. So it just kind of depends on your goals and where you think it would benefit you the most.
Thank you so much. That was perfect.
Thanks, Sarah, for asking that question. Thank you, Dr. Baxter. Next question we have from Hamza. If you want to come off mic and ask a question.
Hi, Dr. Baxter. Thank you so much for taking time out of your schedule to answer our questions. I was mainly wondering about, with regards to like the admissions process and matching. I know you had said that like at that time, letters of recommendation hold a lot of weight, and your grades and being a lopsided candidate and all that stuff. And so I heard that some students tend to take a year off for just research and meaningful projects. And I was wondering if what your thoughts were on that.
Yeah, you can definitely, I would say at the med student level, between within med school and applying to ophthalmology residency, probably 50 or more % of the applicants will have taken a year out during med school in preparation for ophthalmology residency. That's not uncommon in general. I would say more and more med students are taking an additional year for research or for a second degree, but particularly for competitive specialties like ophthalmology, people try to take an additional year to get, some more research experience under their belt. Also part of it too is getting a chance to develop deeper relationships with mentors and people who can write them letters. So yeah, that's certainly something that is more commonly done, but not a must-have, because there are people who go straight through and are, fine through the admissions process as well. So I think you can take, either route. Sorry, you can probably hear my daughter's yelling in the background. I apologize.
No Okay, thank you so much. Yeah, I wanted to ask because I wasn't sure if like taking too many years was frowned upon by admissions committees.
No. It's not frowned upon at all. I would say that if anything, it's almost like more common than not that people took an extra year. And when we look at ophthalmology applicants.
Okay, thank you so much.
Mm-hmm.
Thank you. Next, I'm going to share a poll just to kind of reflect on your amazing presentation. So if everybody could go ahead and put in their answers, and once we have a good percentage, I'll go ahead and release the results for us. Perfect. We've got a large amount of us. I'm going to go ahead and end the poll. So it looks like a lot of people have a more positive perspective on ophthalmology. So thank you so much for your presentation. That is what we like to see for sure. And then the next poll kind of goes hand in hand with this one. So let's go ahead and see that one, and then we'll go back to questions. So everybody go ahead and put in your answers for this poll. Perfect. You guys can go ahead and kind of look at what everybody else in here is looking to pursue. We've got a diverse group, which is really awesome. Okay, and now we can go back to some more questions. Thank you everybody for responding.
Thank you. Okay, Dr. Baxter, some other people were wondering, can you describe what it's like for a typical day in your field? How many hours a week do you work? Do you work every day? Are you on call?
Sure.
More about that.
A lot of that will depend on your practice environment. I would say ophthalmology tends to be, normal business hours type of specialty. So most people work in the outpatient setting. That means not in the hospital setting, but in outpatient clinics. My schedule is a little bit weird because I am an academic, and so most of my time is on research, and then my clinic time is a little bit more limited. But in general practice, I think, and based on most of my friends who are out in practice, it tends to be kind of like an 8 a.m. to 5 p.m. kind of thing, Monday to Friday, depending on if you're full-time. There are people who work part-time, so they'll just work a couple 3 or 4 days a week instead of 5 days a week. Call really depends on what kind of practice you're in. So because I'm at the university, we have residents and fellows who take call. So I actually don't take any primary call for nights and weekends. That was a big benefit of being in academics for my family and being available, and not having to do night, weekend, and holiday call. But in private practice, often the call is split with your colleagues, and a lot of my friends will take a week of call at a time, but they don't necessarily get called in that frequently because there aren't that many emergencies that need to be seen immediately overnight, or if there are, they'll just send them to the university sometimes. So we get a lot of the referrals from practices in the area. But yeah, it tends to be a pretty manageable working schedule. It can also vary by your specialties. So like a general ophthalmologist or an anterior segment surgeon, which includes like cornea, comprehensive, glaucoma, a lot of it, it's anywhere from like 40 to 50 hours a week, or something along those lines. Sometimes retina can be a little bit busier because there's relatively more emergencies, and plastics sometimes too. You have some depending on the type of practice you have, you could have a little bit more in the terms of workload or emergencies and nighttime cases and that kind of thing. But it tends to be, like I said, a good specialty for work-life balance because it tends to be normal working hours, not that many emergencies, and there are opportunities for part-time work.
Thank you for answering. Building off of that, someone asked, you said ophthalmologists have good work-life balance.
Mhm.
Can you explain a little bit more about what you mean by that? Do most ophthalmologists work in a private practice? Is that why?
No, so I think it really, I think you can carve out good work-life balance in most specialties if you, if you're willing to devise your schedule in a way to do so, or there's sometimes, not sometimes, there's often trade-offs with compensation, right? So like if you're trying to make a ton of money and like work a lot of hours to do that, then if you work less, then you may not make as much money. Or like for academics, for example, you make less money than if you were in private practice, but the trade-off is you have residents and fellows to help you take call and that kind of thing. So there are trade-offs, but I guess there's some specialties, that are traditionally associated with better work-life balance just because of more controlled hours and the potential for flexibility and the lack of like emergencies. So for example, when I was in med school and on my OB-GYN rotation, there are a lot of people who still have to stay in-house in the hospital as OBs, well in their 50s or 60s. And like one of my friend's dad is an orthopedic surgeon in private practice who still takes, call every 2 or 3 nights, and he's 60, well into his 60s, getting up in the middle of the night to go operate. And it just happens a little less in ophthalmology, where you have like an intense call schedule and disruption of your normal schedule because there aren't that many middle of the night emergencies. And then, there's some specialties like emergency medicine where you have like defined shift hours, and you don't really take calls, so to speak, but you have different shifts. But a lot of times when you're starting out, you do a lot of nights and weekends. And it can be hard because you're meeting patients when they're really stressed out, they've been waiting a long time, and there's not really that lasting patient relationship where they like think of you as their doctor and they're super grateful. So, um, and also the patient population, like, I only I know more of this because my brother's an emergency physician, but you're really it's all types come through the ED, right? Like drug addicts and people who are violent, people who it's a little bit of a more mixed crowd. And a lot of with ophthalmology patient population, a lot of people are very they're grateful for what you do, and like I said, you get a chance to build relationships with them. So I think that's part of it too.
Thank you so much. Next, a kind of lighthearted question, or what has been your favorite surgery so far?
My favorite surgery is still cataract surgery, and that's why I decided to do it. It's just it's a great surgery, a life-changing surgery, and so yeah, that's my favorite.
Thanks. Next question is, did you ever experience any ethical dilemmas where you had to make a choice of the better two outcomes in ophthalmology?
Ethical dilemmas, I think, there's a lot of different ethical dilemmas that you'll have in medicine. Ophthalmology, I would say, a lot of times we don't deal with too many ethical quandaries. But for example, there was one that just today in the hospital, one of the patients that I saw, the patient with cerebral palsy who's nonverbal. Her brother hasn't seen her since last March because of COVID. She lives in a nursing facility, and she came in because she had a ruptured globe, which essentially means that there was an opening through the eye and some of the eye tissue coming out. She's losing vision in that eye, and it's difficult to examine her because she can't talk, and it's hard for her to follow instructions because of the cerebral palsy. So the question is, we're trying to decide whether or not what to do with the eye. Do we do a ruptured globe repair and try to repair the eye, but knowing that the surgery could cause additional inflammation and harm the other eye, the good eye, and that's an entity called sympathetic ophthalmia. There's discussion of taking out the eye, called evisceration. So we remove the eye altogether, especially if it doesn't have useful vision. And then the question of decision making, right? Like you try to talk to the patient, but the patient she's nonverbal, she can't speak to you, and her decision maker is her brother, and the team right now is trying to decide, well, how do we decide what to do? Are we going to say, we need to take out this eye? And removing someone's eye is a big deal, as you can imagine, to like remove an eye and to know that, that is, that person can even make the decision for themselves. You're talking to their, healthcare power of attorney, who's a brother who hasn't seen her for almost a year. Like that, it's a tough situation that we're like actively trying to resolve. But another example would be there was a young patient with diabetes and this really invasive fungal infection in his eyes. And so the traditional treatment for that is removing the eye altogether so it doesn't invade the brain and kill you. It's called mucormycosis. So this poor guy was like 40 years old, and he had invasive fungal infection in the one eye. So that eye got removed. And then the other eye showed signs of the infection as well. But then, the patient's sort of like, what kind of life am I going to live if I literally have had both eyeballs removed? And like, I'd rather not remove the eye. And so we, at the time, this is a couple of years ago, as a treatment team, we're discussing with him, like, it's a little bit of an ethical dilemma, right? Because your normal course of action is to remove the eye to try to save their life. But the patient's telling you this life would not be worth living if I didn't have any eyeballs left. And so we came to a compromise where we injected antifungal medicine directly into the eye. Even though that wasn't sort of our normal standard of care, but we were trying to honor the patient's wishes. And ultimately, he was able to keep some amount of vision in that eye, and it ended up being kind of like a new innovative treatment approach for that particular type of infection. But that's an examples of some of the, ethical dilemmas that we might come across. And a big part of it is trying to keep the patient a part of the decision-making process, have open communication, and certainly bouncing ideas off others, and not making difficult decisions in isolation, but talking with your colleagues about it.
Thank you for sharing those patient cases with us. It's very much appreciated.
Mhm.
Our next question is, you talked a little bit about your 2 study abroads that you went on. And a student is asking, did you do medicine-based programs for study abroad, or were they just general study abroad programs?
Sure. So the one I did in China was more like medical and clinical shadowing. I was in a hospital and shadowed doctors in different specialties. But the one I did in Oxford was like it was like civil liability law. And so like, I think when I was saying like do non-pre-med activities, that was definitely one of them. And it was really, really, really fun. Like I learned about, I realized like I did not want to become a lawyer, but in the in the process of it, doing the study abroad, it was really interesting to learn about you know, how the legal system is set up, particularly in England. It's basically the foundation or predecessor for the US legal system. There's some application of civil liability law to medicine, obviously through like torts and like medical malpractice, for example. But it was really more focused on general civil liability law. And so I got to work with some law professors from Oxford. And, you go to the high table and talk about like Victorian literature with, different people studying there. And I think it broadened my horizons a lot. And I think experiences like that can help, make you a more multidimensional person, and also appreciate like going into medicine, because I was like, I definitely wouldn't have done law school after that experience. So, but I think it's good to get exposures like that when you're an undergrad, because later on it's a lot harder to kind of do random, academic activities outside of medicine.
Thank you for answering that. Our next question has to do with part of your presentation where you said you were seeing your pre-med friends decide all during their pre-med track that the clinical field was not for them. So the question is, what kept you passionate about staying on the pre-med path and ensure that it was right for you?
Yeah, I mean, I think a big part of it is trying to get exposure and talk to different people in different specialties, and really try to get a full sense of it. So like I said, I did try to do my best and explore a lot of different things. While I was in college, I looked into, teaching and education, like doing the ESL teaching in the evenings. I, did this law program at Oxford because I was like, well, let me see, what that's like. I come in with an interest in medicine, but I wanted to keep an open mind. And ultimately it was doing a lot of shadowing between the study abroad I did in China and also shadowing I did while I was at Duke, that that just like kept me motivated to do it and keep on with this track. Because for me, it was the relationships that you get in that physician-patient relationship is very, very special. And I think it, especially, I mean, I'm biased, like being a surgical specialist, but I do think there's like almost nothing quite as intimate, right, as like letting someone cut into your body and like trusting that to them, and trusting that things will be okay, or trusting that they're going to do their best to do what's right for you. And like for me, I still, obviously I still do research and other activities that I feel like will have a broad impact. And there's a lot of work like that if you work in policy or public health. The idea is to make an impact on an entire population and not just individuals. But ultimately, I knew that I wanted to stay in clinical care because I so valued that individual relationship. And someone saying like, this is my doctor, this is like the person who saved my eyesight, or this is the person who took care of me. And I think that individual relationship is like so important. And I really got a lot out of the shadowing that I did. There was a program at the Duke Brain Tumor Center that I did for many years. And even when people were dying and you really the doctors couldn't necessarily do much to like save their lives or even extend their lives, but that relationship alone was healing in its own way. And I thought that was like very powerful for me. And finding those mentors and shadowing and meeting the patients and the impact that they had on those patients really kept me, interested in the like clinical medicine path.
Thank you so much. I see that Uma has raised their hand, so you can go ahead and ask your question.
So like if you like have a person who's going for a diabetic eye exam, would it be better for them to go an ophthalmologist or like an optometrist, or like wouldn't it like really matter?
For a general screening exam, it doesn't really matter. I think if they have findings of diabetic retinopathy and they need treatment, then they should see an ophthalmologist.
Thank you.
Mm-hmm. Yeah, for initial screening, it should be fine to go to optometrist.
Following up with that, we had another question that was, how do you get a fungal infection in the eye?
Yeah, so sometimes you can get it from trauma. So oftentimes we see people who have had some sort of trauma to the eye, or they get an injury, especially if there's vegetation or organic matter that can cause a fungal infection. You can get an endogenous fungal infection. So if you have a fungal infection in your bloodstream, then like candidemia, candida is like a yeast, and that's a common infection that, or not common, but it's among infections you can get in your bloodstream. It's relatively common, and we'll see it in hospitalized patients, particularly those with cancer or other immunosuppressed conditions. And then they can get a fungal infection in the bloodstream that then goes to the eye. Or in the case of mucormycosis, which is the case that I was discussing, you can get, mucormycosis or aspergillosis, different kinds of fungal species. Commonly they'll go in through the like sinuses and nasal cavities, and then from there travel to the eye. And that's we typically will see those in people who are immune compromised. So people who have been on chemo and cancer, diabetes, and other, immune suppressed conditions.
Thank you so much.
Mm-hmm.
Our next question is, have you seen physicians who finish medical school in their 40s and 50s?
Yeah, I remember in my med school class within my like small group, we had someone who was starting med school in her 30s. And then my husband, who was in med school, he was at a different med school, but I was at Penn, he was down at Hopkins. They had someone in their, I want to say late 30s or early 40s who had had a whole career as like an NYPD officer before doing med school. So yeah, we definitely see people who enter medicine later in life. Even my own father-in-law was a lawyer and then didn't start med school until his mid 30s, and has had a very successful career and is still practicing medicine now, and he's almost 70. So I think you can have, luckily medicine, a lot of people will do it for a long time. So it's not like being a pro athlete or something, although I guess Tom Brady's also showing that age is not a limit to elite athletic performance. But yeah, like for medicine, the career path is long, and I think you can have a very successful career even if you start later.
Thank you so much for your presentation and for your Q&A. The entire session was amazing, and we appreciated all of your insight. And just to finish everything up, do you have any final advice that you'd like to share with us today?
I guess I probably covered most of it in my presentation already, but I do think that I had somewhat of a unique path starting a family early, and it really forced me to take a look at my priorities and what I wanted to get out of life and out of this career. I will admit, like at the very beginning, I was a little overwhelmed, and when I knew that I was going to be starting a family, I felt like, oh, how am I going to do this? How am I going to get through med school? And I would just tell everyone here that, a lot of it is just keep on trying and do your best, and just trust that things will work out. And sometimes it doesn't always work out the first time. I've had even in my academic career, like any academic will tell you, like lots of rejections, unfunded proposals, you know, applications that didn't go through. And you see all these people and you're like, wow, they have such a great resume. They got all these awards and they have so many accomplishments. Like I could never be like that. But then what you don't see is like 5 times the amount of rejections that they got and all the things that didn't work out. And I think it's important to keep that in mind, especially when you're young and you're getting started on this path. It's easy to feel overwhelmed or intimidated, but just know that people went through this process before you, and it's not always a smooth ride, and that you can't control or predict everything. Like unexpected things will happen, and challenges will arise that you couldn't anticipate, but it's all about how you approach those challenges and keep on trying. And I think, you know, ultimately that persistence will pay off.
Wonderful. Thank you again, Dr. Baxter, for joining us today. It was such an honor to have you, and you're such an inspiration to all of us. So thank you so much. For all of my students, if you guys are interested in taking the post-shadowing assessment, I'm going to go over how you guys can do that in my little presentation here at the end. And we're also going to be announcing the winner of today's raffle. Okay, so just really quickly, we like to do this. This is not something that you guys have to submit for proof that you guys are here or anything. This is just for you. So just a reflection. You're going to be applying to various programs in the future. You know, why are you here? What inspired you? What motivated you to even join us today? Because that's a big part of your journey. What part of today's session resonated with you? And what are 3 key takeaways that you're going to take away from today's talk and implement into your life? And so these are just things to think about. You don't have to submit these. However, if you do want to, we would always love to hear your guys' feedback and your personal experiences. You can actually get published on the official Pre-Health Shadowing website. prehealthshadowing.com/blog submissions is where you will be submitting that. You can submit your reflection from the session today. You can submit any articles, reviews, or success stories to be featured on the official Pre-Health Shadowing website. You can add this to your applications, your CVs, your resumes, and your LinkedIn profile. Bye. Thanks again for joining us.
Thank you. Thank you everyone for this opportunity, and best of luck to all of you.
Thank you.